Hello, and welcome to the Families USA Health Action webinar today. I'm Patrick Willard, Senior Director for State and National Strategic Partnerships here at Families USA, and we're welcoming you to our Health Action webinar on Medicaid proposals facing scrutiny. We thought this would be a good time to focus on what's happening in the world of Medicaid waivers and the proposals that are going on across the country, not just in the states, but also at CMS and on the administration side. We've had a lot of activity over the course of the past several weeks around Medicaid waivers, as well as since legislative sessions began at the beginning of the year. But this month has been an especially critical time for attention to these Medicaid waivers because of the discussions around work requirements, around block grant proposals, and around other ideas of ways that the administration could end up restricting access to Medicaid through a number of different avenues, including the work requirements, block grants, and other restrictive measures. What we've seen over the course of just the past week has been impressive as well. There were hearings in a federal district court here in Washington over the Medicaid work requirement waivers for both Arkansas and Kentucky, and we'll be hearing a little bit more about that from Eliot Fishman here in a moment. We also had the Secretary of HHS appear before congressional panels last week, where he was asked about what was going on in terms of the work requirement waivers and other advice and guidance that the department was giving to states. He mentioned at that time that the department was actually talking with states about block grant proposals and other ideas, but he refused to give information about how many states they'd been talking to about block grants or what kind of block grants those were going to be. In addition, we've heard that there is guidance that's being prepared around these 1115 waivers that is over in OMB right now and will be released shortly. So today what we wanted to do was to give you a chance to focus on what's happening in the Medicaid waiver space and also get yourself prepared for both how to react once we get some action taken on the federal court level, which we're expecting within the next 2 weeks, or how to deal with these Medicaid work requirement proposals or other waiver ideas that are going to be coming down from the state. So for our agenda today, let me just say first, right off the bat, that what we're going to be doing is recording this presentation so that people will have access to it after we finish today. We'll make these slides and the recording available to folks and send that out in a follow-up email. We would also encourage you, if you have questions, to go ahead and type in your questions in the chat box. We can have those questions ready and be able to answer them once we finish the presentation. But it's best if you go ahead and type up any questions you might have as soon as they come into your mind so that we know that you have a question and also we'll be able to get ready to respond to it as quickly as possible. So our agenda for today is our opening, obviously, and then a conversation with Eliot about what's happening in the courts and on the administration side in terms of work requirements. Then we'll hear from Sophia Tripoli about what is happening in the states and especially how states have been dealing with these proposals around Medicaid expansions, where we've seen those in both Utah and some other states. And then finally, we'll hear from Kathleen Stoll, who has been successful in actually fighting back proposals for work requirements in the state of West Virginia. So we will end that with a question and answer session where we'll try and wrap everything up. I would say that it's especially important right now, given what's happening in state legislatures. Just yesterday, we saw that a bill passed in the Senate in Iowa that had work requirements. We know that in Kansas right now, they're actually talking about Medicaid expansion on the House floor. So these are issues that are happening right this moment, and we want you to be prepared for not only what is happening now, but the results from the courts, the results from the administration, and the results in your own state legislatures. So at this time, I'm going to turn the program over to Eliot Fishman to talk a little bit about the court hearing that was last week and the other activities that are happening in the administration. Eliot.
Thank you, Patrick. So the hearing on March 14th was regarding, it was actually 2 hearings back-to-back regarding first the state of Arkansas and second, the state of Kentucky. And it won't surprise you that Arkansas's terrible numbers around disenrollments in the last 4 months of 2018 were really at the center of the hearing as a vivid demonstration of how these waivers are really antithetical to the objectives of the Medicaid program. And given that the statutory requirement around Medicaid waivers is that they promote the objectives of the Medicaid program, those Arkansas numbers are really devastating for the administration and the states of Kentucky and Arkansas's legal case. Those parties, the defendants in these hearings, made 3 arguments. The Judge James Boasberg, who also ruled against Kentucky and the administration last year, was skeptical of each of those 3 arguments. So the first argument was that these waivers are for financial independence. It's a rigmarole that I think everyone associated with these waivers has heard before about how really taking away Medicaid is good for people. The judge cut that off quite definitively in stating, look, that's not the purpose of Medicaid, and referenced his opinion from last year. So that left the defense making the argument that while states will undo the Medicaid expansion if they don't get their way on these Medicaid waivers, and both the judge and the plaintiff's attorneys were concerned that you could make that argument for anything, right? You could do anything negative in Medicaid and say, well, if we don't get our way on this, we're going to undo the Medicaid expansion. And the judge asked for some sort of a limiting principle on that kind of an argument and didn't get one. Third, the states tried to make the claim that this was going to help them manage the costs of Medicaid expansion, that this made it more fiscally sustainable. And the judge, again, was very clear that that wasn't the claim that they made in their waiver submission. That wasn't the claim that the Department of Health and Human Services reviewed. And those of you who have been following closely the rationales that are used by people like the Bevin administration in Kentucky know that they've kind of tried to have it both ways on whether this is about saving money or not, as has the Trump administration. So effectively, every argument that the defense brought up was pretty clearly met with skepticism by the judge. He said he would be issuing a decision, if at all possible, on both states by the end of the month. So that means effectively in the next 10 days. We think, given how the oral argument went, that he'll be ruling against these states. And in terms of the legal process, there is almost certainly going to be an appeal to the D.C. Circuit Court, and that will play out over the next several months. So in anticipation of what will hopefully and again likely be a ruling against Arkansas and Kentucky, some thoughts in terms of messaging. So the first thought is to note that although this is a decision that is potentially going to be appealed, that it is also a decision that is strongly grounded in the statutory definition of Medicaid, right? To say that Medicaid is about medical assistance, which is literally the name of Title 19 of the Social Security Act, it's just not a big stretch. The second thing to note, which I think is important to emphasize, is that Arkansas's bad numbers do not primarily reflect that Arkansas made a lot of implementation decisions that inflated those numbers. In fact, really the contrary. So while it is true that Arkansas's website was apparently difficult to navigate, Arkansas also made a decision that it did not need to make to accept old employment and income data and exempt people based on that old data from reporting. And in general, we think that Arkansas's numbers could easily be more of a best case scenario than a worst case scenario in terms of levels of disenrollment. That ought to be a strong point of refutation to people who are saying, well, we'll do it better than Arkansas did it. Clearly, what Arkansas shows is that these waivers involve a lot of red tape, and that you lose many more people to that red tape than to the underlying changes to eligibility. And it's also, particularly following on this decision, important to note that pursuing these kinds of programs involves a huge amount of delay and distraction for Medicaid programs. The Bevin administration has been in office now for going on 3.5 years and has been pursuing this waiver essentially that entire time with no results yet. In Utah, there have been pushes around some sort of a waivered partial expansion kind of structure going on. Again, now for almost 2 full terms of the governor of Utah since 2014. And I think that's an important new talking point that comes out of this likely to be successful litigation, that you are just introducing potentially into your state Medicaid program, into your state healthcare system, years of wasted effort and uncertainty. When that decision comes out, again, likely towards the end of the month, Families USA will come out with both a short press statement and a short analysis. So please keep your eyes open for that, and we will circulate those widely, and hopefully those are useful also for thinking about messaging. One more thing specifically for folks who are calling in from Kentucky or Arkansas is our experience with Kentucky in the aftermath of the decision last summer was that there was an initial effort by the governor in a vindictive manner to pull vision and dental benefits for the adult population in Kentucky, and we would be on the lookout for that kind of an effort again in Kentucky and possibly in Arkansas as well. Okay, now to speak more broadly to the recent developments coming from the administration. As Patrick mentioned, there is guidance that is now at the last phase of review, so sitting with the Office of Management and Budget, that is going to make an offer to states to use Medicaid waiver authority to impose a block grant or per capita cap structure. And that kind of a structure has 2 sides to it. One is the federal government capping its liability and putting risk onto states for Medicaid costs beyond that cap. And the second side is that states get some ability, and we won't know until we see the guidance, to waive core parts of the Medicaid program. So as to whether that includes, for example, an offer to waive EPSDT benefits for children or other really elements that have not been waived before, I think is likely, but we don't know yet. And as Patrick alluded to, Secretary Azar was very cagey about this when he was asked about it during his recent congressional testimony. But we need to collectively be watching both sides, right? So how punitive those caps are. It seems like some conservative state legislators and governors are seeing caps as an affirmative good. There's no scenario in which, if you are responsible for balancing your state budget every year, that it's a good thing to cap federal liability and leave your state holding the check for the rest. But also what protections are put on the table in the name of state flexibility. There have also been some state legislators or governor's officials in states that are pursuing partial expansion So in particular, this has come up around Utah, Georgia, and possibly in the context of Tennessee, that in this big package of capping federal liability and waiving other state requirements, that some states will be able to access enhanced federal match for only covering the 0 to 100% of the federal poverty level portion of the Medicaid expansion population. So first, I think there needs to be a certain amount of skepticism of these claims. There hasn't been anything from the Trump administration at all, except as mediated by Republican legislators who have their own agendas. That is certainly very much the case in Utah, in which they were pushing to repeal and replace the state's ballot initiative around doing full expansion. So in general, it's not clear what really is going on federally around partial expansion as part of this potential guidance. But the idea that the federal government could allow some states to get that enhanced match and not others to get that enhanced match is legally very hard to understand. In general, the legal status of enhanced match for partial expansion is dubious at best, given that, as we all know, that's not how the law is written. But certainly the idea that they could make a determination that the same person is eligible for enhanced match in one state but not eligible for enhanced match in another with the same eligibility definitions seems, again, to be legally without any possible basis and likely to be challenged. There was additional guidance that has been officially released late last week on work requirements involving detailed requirements for states and monitoring and evaluation of those waivers. I would say in general that is kind of window dressing around waivers that are clearly fundamentally opposed to people having coverage. But it is notable that with that announcement around that guidance on monitoring and evaluation, that Seema Verma, the administrator of CMS, put out a blog on state flexibility. It repeated what has been her rebuttal or effort to rebut criticism of these waivers, that people are not appreciating that they are actually sincere efforts to help people get employment. So that is, in a way, showing that the criticism, I think, is to a significant extent finding its mark. It was a similar kind of bitter tone that she has taken before. But in particular, there was a huge contrast between her justification around state flexibility and the Trump administration's budget proposal that came out at the beginning of the week last week. So the Trump administration's budget proposal said that the administration supported making work requirements mandatory in Medicaid and SNAP on all states, and actually projected $130 billion in Medicaid savings over 10 years from making work requirements mandatory. Obviously could not be further from state flexibility than mandating that every state in the country impose work requirements. So just a glaring contradiction between those two different parts of the administration, I suppose, saying opposite things on whether Medicaid work requirements are an element of state flexibility or something that the federal government should be mandating on states. So with that, I have completed my brief review of litigation and administration developments, and I am going to hand the mic over to my colleague, Sophia Tripoli, to speak to developments at the state level.
Awesome. Thank you very much, Eliot. I'm going to talk a little bit about what we're seeing in state legislative sessions on Medicaid efforts to fully expand, as well as partial expansion, work requirements, and block grants. So the first slide here is our 50-state look at Medicaid expansion. And building on the efforts to expand Medicaid over the last several years, the successful ballot initiative efforts in November elections were able to bring 2 additional states onto the list of states that have expanded Medicaid, bringing the total number of states who have expanded Medicaid to 36, including the District of Columbia. We now have 2 states, Utah and Wisconsin, that are implementing Medicaid expansion for people between 0 and 100% of the federal poverty level, and we're going to talk in just a minute a little bit more about both of those states. And we have 13 states that have not yet expanded Medicaid, and just in a couple minutes we'll talk more about which states are considering taking up Medicaid expansion through their legislature. So first, I want to just walk through where Medicaid expansion stands in the 3 states that expanded Medicaid through ballot initiative efforts in the 2018 elections, starting with Utah. The Utah legislature started out their session with a pretty concerted, fast-paced effort to repeal and replace the ballot initiative. Conservative members in both chambers worked several versions of Senate Bill 96 through procedures to ultimately repeal Proposition 3 and replace it with a bill that would do a few things. First, it directs the state to continue to seek approval for its Section 1115 Medicaid waiver that was submitted to CMS in June 2018 and is currently pending. This waiver seeks to expand Medicaid up to 100% of the federal poverty level with a request for the enhanced federal matching rate. It also includes work requirements, caps on enrollment, and a request to waive EPSDT for 19 to 20-year-olds. SB 96 also directs the state to seek a Medicaid waiver that expands Medicaid up to 100% of the federal poverty level at the state's regular matching rate. It also incorporates a per capita cap on federal reimbursement, limits presumptive eligibility, and imposes a lockout period. Importantly, as Eliot mentioned, CMS has not approved an expansion of Medicaid up to 100% of the federal poverty level with the enhanced federal match. This was a major point that supporters of Proposition 3, state advocates, and national partners pushed hard on during Utah session to stop the repeal efforts. But some Utah lawmakers have stated repeatedly that they are in negotiations with CMS about making this deal. It is because of the efforts of state advocates on the ground pushing the message that CMS has never approved a partial expansion with the enhanced federal match that the final version of SB 96 includes a stopgap measure to address that concern. SB 96 says that if the federal government does not approve the state's Medicaid waiver, then the state is directed to expand Medicaid up to 138% of the federal poverty level with certain cost controls. We anticipate CMS to make a decision about Utah's existing waiver in the coming weeks. And CMS's decision on the waiver could play out in various ways in terms of the partial expansion, block grants, work requirements. And Families USA is tracking this very closely and will be sharing resources with state partners to understand the impacts of that decision as well as next steps in Utah. But for now, enrollment for Utah's partial expansion is to begin on April 1. In Idaho, the state is moving forward with implementing Medicaid expansion as the ballot initiative intended. The state submitted its state plan amendment to CMS in February and is accepting public comments on that plan through March 22nd. The estimated enrollment start date is January 2020. The Idaho legislature has had a few attempts to make changes to the ballot initiative, including a recent bill that was introduced in the House that would impose a work requirement on the 100 to 138% of the federal poverty level population under the Medicaid expansion. There is a committee hearing on that bill today. State advocates have been working throughout the session to defeat attempts by the Idaho legislature to impose work requirements, and they are in the final stretch of that fight as the end of the legislative session nears. Nebraska is also moving forward with its Medicaid expansion implementation, and the state is required to submit their state plan amendment by April 1, which is just in a few days away. Next slide. There are several other states to watch as far as Medicaid efforts, whether it's partial expansion or block grant efforts. Wisconsin's Section 1115 Medicaid waiver was renewed, as folks know, and extends Medicaid coverage to all non-elderly adults up to 100% of the federal poverty level. And in Wisconsin, they use a combination of their state plan and Section 1115 waiver authority to implement that coverage at its regular state matching rate. Georgia lawmakers are considering SB 106, which would authorize the state to seek a Medicaid waiver to expand Medicaid up to 100% of the federal poverty level and to also seek a 1332 waiver from CMS. SB 106 gives a lot of deference to the state to shape both the Medicaid 1115 waiver and the 1332 waiver. SB 106 passed the Senate before the March 7th crossover date deadline and is now on the House side for consideration. Oklahoma lawmakers are also considering a bill, SB 605, that directs the state to seek a Medicaid waiver to expand Medicaid up to 138% of the federal poverty level through the Oklahoma plan, which would offer one or more commercial insurance options for Medicaid enrollees to purchase their coverage from. The plan would include work requirements and would be seeking approval to use premium tax credits or cost-sharing reductions to purchase coverage through the Oklahoma plan. The bill has undergone some procedural changes, meaning that it could be significantly changed. And then in Tennessee, lawmakers are pushing HB 1280 and its companion Senate Bill 1428, which direct the state to submit to CMS a Section 1115 Medicaid waiver amendment to TennCare for a block grant. And there is a hearing on those bills today in Tennessee. Next slide. The last two states to watch out for expansion efforts are Kansas and North Carolina. In Kansas, Governor Kelly released a proposal to expand Medicaid in the state and is working with lawmakers and advocates to find a pathway through the Republican-controlled legislature. And we are just hearing moments before the webinar that the House has decided to move forward with hearing and debate on Medicaid expansion there in Kansas. And in North Carolina, Governor Cooper, Democratic members of the legislature, and state advocates are also working to find a pathway to expand Medicaid. And their biggest hurdle is the Republican Senate majority in North Carolina. As you can see, there is a lot happening on Medicaid in the states this session. Advocates are working hard with partners to push for expansion where they can and to fight off bad expansion proposals, block grants, work requirements, and other legislation that would restrict access to Medicaid coverage. We want folks to know that Families USA is here to help. We're here to provide resources and critical information about the impacts of federal guidance, court decisions, passage of state laws, and to highlight victories where we can get them. Obviously, folks are, work requirements is top of mind for Medicaid advocates as we're waiting to see how Judge Boasberg will rule on Arkansas and Kentucky. In the meantime, state lawmakers continue to push work requirement legislation for the Medicaid program. Just yesterday, as Patrick mentioned, lawmakers in Iowa passed a work requirement bill. But we've also had a few wins on the work requirement front. Advocates in Wyoming and West Virginia were successfully able to defeat efforts to pass work requirements just weeks ago in their respective legislative sessions. Our next speaker is Kat Stoll from West Virginians Together for Medicaid, who will share their incredible story and what it took on the ground to defeat work requirements in the West Virginia legislature. Kat, thank you very much for being on today's webinar, and I'll turn it over to you.
Thank you. Let's move on from that slide quickly. There we go. I'm here in West Virginia, and we have defeated work requirement proposals 2 years in a row here. And I apologize if you can hear my dogs barking in the background. I work from a home office. We have a very red state now. In fact, we duke it out with Wyoming to have the state where President Trump polls the most popular. So we're dealing with a very red legislature, which over the history of West Virginia has not been the case. And our governor, of course, switched from the Democratic Party to the Republican Party his first year in office. So we knew we were going to have a Medicaid work requirement proposal come forward in 2018. You can go to the next slide, please. So in 2018, we knew it was coming, and we prepared a number of materials that I've asked Patrick to share with you all, perhaps on the website that you set up for this webinar. We did short talking points, a longer FAQ document. We did PowerPoints, and we had the West Virginia University prepare for us a report with their stamp of credibility about the impact of a work requirement, not only on enrollment, where they found about 144,000 folks could become disenrolled, which is a lot in West Virginia, but also could point out that it would take 30 to 40 new employees at our DHHR in our Medicaid agency just to implement this, and also talked about the complexity of trying to make it work through computer systems, et cetera. So we had that WVU, that's West Virginia University report. We also had a couple legal memoranda that we put together that talked about the threat of litigation if you move forward. So we weren't sure if it would come up. It did come up through the regular legislative process in 2018, and I just put on this slide what worked best for us. And what worked best for us, and there was no question about this. In fact, it was acknowledged by our Deputy Director of DHHR. The threat of litigation made our legislature very nervous. And our DHHR did not want to do work reporting requirements. And so they were behind the scenes quietly helping us. And so we sent them memos that said, look, if you do this, you're going to get dragged into a lawsuit and it's going to cost you tons of money. And that was really a very persuasive argument. Administrative costs, again, 30 to 40 new full-time employees. We also were able to point out the impact on rural hospitals and providers if people were knocked off Medicaid. And also our state had a great sense of pride as the first state who had moved forward with an SUD waiver, substance use disorder waiver. And we could argue that that progress would be undermined if many people would lose their Medicaid eligibility due to a work reporting requirement. And just a note that when I say we, it was actually a Medicaid coalition that originally came together to pass the Medicaid expansion in West Virginia. We were one of the first states to do that. About 40% of our total state population, from children through folks who are Medicaid dual eligibles, it's 40% of our population relies on Medicaid. And we do a lot of work at the county level with dollars and enrollees, county data that we share with the legislators and county commissioners to sort of drive home how important the program is to our state. So it was a broad-based coalition. It included our hospital association, it included our medical association, and our West Virginia Rural Health Provider Association. So that providers were real key. So if you go to the next slide, can you guys go to the next slide? There we go. Yeah, you're there. So we thought we knocked it down. It didn't go very far in 2018. We had a hearing and it wasn't gaining a lot of traction. So between the end of the legislative session in 2018 and looking through last summer at what would come up in 2019, we decided not to talk about work reporting requirements publicly. We weren't going to do op-eds in the paper about how awful they are, and we didn't go to our legislature with the issue. And the thinking was, let a sleeping dog lie. We knocked them out, and let's not keep this issue fermenting because our leadership is Republican. They're gonna perhaps bring it back, but let's not fan the fire. There was a little disagreement about that strategy, but in the end we sort of found a compromise, and we reached out to all of our provider associations again and did a lot of education on work requirements. We did webinars for the West Virginia Rural Health Association. We sat down with the folks at the Hospital Association, and we met with key members of the Medical Association, reinforcing how bad this would be. So we didn't think we're going to have it come up. And actually, we were almost done with our legislative session. And on the last possible day in our legislative process, you have to read a bill 3 times on the floor of a chamber before it can move forward. In the House, the last possible day, the committee, the Health and Human Resources Committee, had a committee-produced bill. So there wasn't a key sponsor. It wasn't introduced. And we all knew about it. The committee itself generated a bill on the last possible day. The day before, the agenda for that key committee showed that there was now a bill that would create a work reporting requirement, and they would vote on it the next day. So we knew this was a sneaky process, that it was a way of avoiding a public debate as we had the year before. We found out that not even our Department of Health and Human Resources knew this was going to be on the agenda. And lo and behold, some out-of-state witnesses were ready to speak at the committee vote, not a hearing, but actual vote, about how wonderful it is for folks to have to work. we were able to throw together some folks, had a couple people at the committee vote who raised questions about it. Ted Botner, who's a leader of West Virginia Center on Budget Policy, was there, and we fed a bunch of questions to our Democratic allies. And all of the questions were about the process, really. At that point, we wanted to stop it on a process argument rather than try to re-engage in the substance of the issue. We also quickly reached out to our provider associations, told them this had popped up, and we were able to get it put on hold and then eventually defeated it. On really the second year on the sneaky process arguments, on the fact that it was brought up so quickly, there was no fiscal note or cost estimate for the bill. Just a process that allowed us to say, and we'd had a couple other bills move that way that were key in the legislature, so we could say, here they go again, they're being sneaky. We also at that hearing, or I'm sorry, a committee vote, we were able to circulate a memo again saying you're going to get sued. We guarantee it. We had a legal services memo that said we'll pursue litigation. And we had the federal court hearing on March 14th to point to in a few days, so that helped us. So go to the next slide, please. So that's what helped us. What I wanted to comment on is in West Virginia, what did not work very well to stop it in either 2018 when we were in a more substantive argument posture, or in 2019 when we were really more arguing the procedural process problems. We did not find that estimates of loss of coverage, even though we had them from WVU, were that persuasive. And I think it's obvious to anyone who works in a state with Republican leadership. They want to knock people off Medicaid. They don't say that, of course, but there is so much misperception of who Medicaid enrollees are and such an underpinning ideology that folks ought to pull themselves up by the bootstraps, et cetera, and that we need to kick the scammers off who are able to work and just don't choose to do so. And, of course, we have a very high unemployment rate in West Virginia. So estimates of loss of coverage was almost, for some Republicans, exactly reinforcing the point that there must be a bunch of, bums on the program. Also, we didn't find that alternatives that truly support work were working arguments for us. I think they could be, but they weren't well enough developed in terms of exactly what we were talking about. We were indicated a Montana-like program, but then Montana was changing. So what we really found that those didn't work for us. They may very well work in other states. When we brought up in 2019, you're going to knock folks off we are desperately need to get into SUD treatment. We need early intervention so that they don't have an opiate addiction problem. You just passed this SUD waiver in our state. You're very proud of it. You're going to undermine that work. We didn't find that worked either because they quickly said, well, we'll exempt people who are in SUD treatment. And the definitions were pretty narrow of how you define who's in treatment. And, of course, that doesn't deal with the issue of early intervention so people don't become addicted or have an SUD. But we just found that as soon as we raised that, they'd go, we'll take care of those folks. We'll do an exemption. So I just mentioned that. If you go to the next slide, please. So now we're looking, this is just a few notes about in 2019. Again, we focused our educating on our allies in the provider community and not tried to talk to Republican legislators. And I should say we got all of our materials together ahead of time. We had talking points. We had longer issue briefs. We had frequently asked questions. We had the WV report. We put all that in place because we knew we could likely see this, but again, we didn't want to be the ones to raise it. We had op-eds ready to go if it came up. Next slide, please. So that's kind of how it played out in West Virginia, and I've said to others, in some ways we were lucky. Their own desire to try to sneak this through really helped us in 2019. And in 2018, I can thank our allies in Kentucky and now Arkansas, who brought the litigation, and our friends at the National Health Law Program, Families USA, and others, because the litigation was really our strongest argument. We do expect to see it come up again in 2020. We're going to have some key Republicans who are truly committed to trying to bring this forward. They're being taken to conferences and wined and dined by folks who want to pursue this in our state. We think that the outcome of the case, the Kentucky-Arkansas case that Eliot talked about, will be a key factor, even if it goes up on appeal, which it certainly will. It's going to be a discouraging factor. Before it's unsettled litigation, then if we have a negative decision, it'll be unsettled, and we know it may not fly in the courts. One of the things we worry about is if this issue has a higher profile in Congress along partisan lines. So if there is some effort by the Democrats in the House to prevent work requirements at the same time that Trump in his budget has already drawn the line that he is embracing work requirements, it becomes a more partisan issue, and that will make it harder for us to fight it in West Virginia. It will become more of a touchstone issue for our Republicans. The impact of the new federal 1115 template and guidance that just came out last week now is minimal. That just doesn't even enter into the dialogue in our state. DHHR in our state does not want to do Medicaid work reporting requirements. And you'll notice I always try to say Medicaid work reporting requirements. So we try to emphasize this is about, we have a libertarian, underpinning in our state, and this is about reporting and having your boss have to be involved if you're working. And we emphasize that it's a reporting requirement that doesn't create jobs or give you training to get a job. We are talking with DHHR about developing an alternative Medicaid work transition program, some sort of would take an 1115 waiver probably to allow folks to stay on Medicaid when their income goes above 138% and they're transitioning over to the marketplace. Also looking at some other programs within our work and training programs here. We got a little bit more funding for several of our work and training programs in the state this year. So how can we better use that strategy? As yes, we all want people on Medicaid to transition to work and economic independence, but what are the real tools that can help them? Trying to develop that strategy so it's more effective than it has been by having it be more specific. I think that's about it. I don't think my experience has been any different from any other state, but I always welcome hearing from other states what arguments are working for them, because this is what's worked for us, but may not be what works in 2020. Thank you.
Thanks, Kat. We appreciate it, and I do think that you guys have sort of been ahead of the game and worked some of these things out. I think your approach in terms of talking about it in work reporting requirements obviously makes a distinction there that can be used in a state like West Virginia and some of these conservative states where they don't want to have to worry about reporting to the government, and their bosses don't want to have to feel like they have to do some additional reporting. So I think that's a good piece to have as well. And obviously we are worried about, the more states that we can have stop these work requirements, like West Virginia and Wyoming and other places, the harder it's going to be to make the case that states want work requirements when it comes to Congress. And if we can continue to see a split Congress, it'll be tougher for Congress to get into the conversation in terms of thinking about work requirements or taking something like that up, because they know it would be divisive in Congress. And in addition to thanking the folks in Kentucky and Arkansas for filing suits, you can now add New Hampshire to the list. While we've been holding this webinar, the InHelp has filed lawsuits in New Hampshire on the work requirements proposal there. those work requirements were supposed to take in effect in April for current enrollees, and so now there is a lawsuit involving New Hampshire on work requirements. So we have 3 states that are involved in that. And so just to sort of go to questions and sum up, I think one of the things we've seen, obviously, is that work requirements and the legislation around work requirements and everything about the lawsuits on work requirements is happening both in expansion states and non-expansion states, and is an issue that is involving the bulk of conservative states that are out there. And what happens in terms of this lawsuit that we expect to hear about by the end of this month will have an effect on that. But in addition, around the Medicaid expansion conversations, there has been this idea of using waivers for block grants and for the potential for partial expansions. And I just wanted to quote something that Secretary Azar said at the Senate Finance Committee last week. He said, "We have discussions with states where they will come in and suggest ideas. There may be states that have asked about block granting per capita, restructurings around especially expansion populations. It's all at their instigation." And so HHS is doing this. Further down in this article, there's a Medicaid lobbyist who's quoted in saying, "It's definitely an outreach and encouragement. The administration is saying, quote, we're open and we want to talk." And so I think that's what we're seeing here is an administration that is encouraging states to develop these ideas around block grants and partial expansions and suggesting that they'll at some point be able to get approval for those. And that's especially playing out in these expansion states, which is why we're seeing it not just in Utah, but also in discussions in Georgia that are going on now. And I think that is part of the conversation that's going on in Oklahoma, where they haven't really developed the proposal, but seem to want to perhaps avoid a ballot initiative and pass something in the legislature that would allow them to say that they've dealt with this issue. I want to go to the questions that we've had, and one of the first questions we've had is around Kentucky and some of the projections that have gone on there. One of the things that they've seen is that there have been conversations around administrative costs increasing more than 40% because of the infrastructure that would be needed to track the work requirements. So do we know of anyone who is tracking what these administrative costs are or what's been going on around the administrative costs? And I'll turn that over to Eliot.
Sure. So Kentucky is the state where those administrative costs were made most explicit. It was a line item in the budget, and it came to several $100 million. Other states have been all over the place in terms of their reporting on those administrative costs, and it's also notable that CMS has really given states a lot of latitude to not include that kind of information in their formal proposals. So the recommendation in terms of making the case around administrative costs that we would make is really to look to the Kentucky number, and we're happy to direct folks to that if it's helpful via email.
Thanks, Eliot. We had another question about the Georgia proposal, and that bill has been passed in one chamber and is awaiting action. I think is scheduled for a hearing today in a House committee. But Sophia, can you tell us a little bit more about the Georgia legislation?
Sure. I think so. At this point, SB 106 is the bill, and right now it provides a lot of deference, a lot of sort of authority to the state if this is were to pass, to sort of decide what the elements of both the 1115 waiver but also the 1332. So I think it's a little bit remains to be seen. One thing to note there is that the governor is behind, as far as we know, supportive of those efforts. So I think we'll have to wait and see what some of the detail looks around the 1332.
I think that's similar to what's going on in Tennessee, where the legislation there does say that it should be used for a block grant proposal, but it, again, leaves a lot of the nuts and bolts of it to the administration to first seek a waiver, and then in seeking the waiver be able to design what the program is going to look like. And given the conversations that are going on between HHS and state officials and state lawmakers, that seems to be what we're hearing from those state lawmakers, is that they're hearing a lot from CMS on these issues. And so I think that the other question I think that we have is on the block grant proposals. Is this something that the administration has the authority to do, or what could be the holdup in terms of approval for a block grant plan? And is that something that we would expect to see in any waiver that would come down for Utah? And I'll throw that to Eliot.
Sure. So in broad terms, the federal government has the ability in an 1115 waiver to put in some sort of a cap on federal financing. The federal government has long done that under budget neutrality. But those caps were always set based on historical state Medicaid spending or based on national Medicaid state spending trends. They were never set in a way to reduce federal liability significantly beyond what it otherwise would have been. And you couple that, remember, with the fact that this guidance is not just going to be about capping federal liability, but also reducing federal Medicaid protections, benefits, eligibility levels, all elements that remain to be seen when the guidance comes out. So you combine the fact that this is going to be capping federal liability in a way that Congress rejected, and that's going to be paired with a bunch of restrictions on otherwise statutorily required parts of Medicaid, and it looks vulnerable to the same sort of legal challenge that this is not promoting the objectives of the Medicaid program, it's actually hurting the objectives of the Medicaid program. So everybody who's involved with the litigation around work requirements is watching this really closely, and I think there's a very high chance that there will be litigation if and when some state tries to do a restrictive waiver under this guidance.
Thanks, Eliot. We have another question about the New Hampshire lawsuit. Is it a class action suit? Who's bringing the lawsuit? The lawsuit is being brought by InHelp, which was also behind the lawsuits in Arkansas and Kentucky. It's being filed on behalf of 4 New Hampshire residents who are enrolled in Medicaid, including one who is an agricultural worker who works seasonally and so therefore might be at risk of losing coverage because of the seasonal nature of the work. So again, it's InHelp. It is again being filed in the U.S. District Court in the District of Columbia, and involves these 4 residents who are currently receiving Medicaid. So that's what we have on the New Hampshire lawsuit at this time. We'll be following up from this webinar and sending out the materials, some of the materials that Kat put together for West Virginia and how they were successful. Another item that we'll be sending out is a report that was put together just this week by the Commonwealth Fund that talks about how Medicaid work requirements will affect hospital finances. This is a study that Commonwealth has put together that looks at the impact in Arkansas and extrapolates from that what the work requirements would mean for hospitals, their rate of returns and loss of coverage that may be useful to you in terms of fighting the work requirements in your state. And then we'll also, of course, be sending out the recording that we have here and the slides. So if you have any questions, feel free to reach out to us at info@familiesusa.org. And you can look on our website for some of the toolkit that we have provided to help states fight work requirements, and look at the materials we have there for different messaging approaches and strategic approaches you can use to fight those work requirements in your states. Finally, I think that one of the things that we have seen, and the Center on Budget has taken time to look at, is how the Arkansas work requirements have actually impacted folks in the state and the 18,000 people that lost coverage, and the fact that people are not finding jobs. One of the things that Secretary Azar suggested in his testimony last week was that these people who had not re-enrolled in the Medicaid program had perhaps found jobs. And Center on Budget has taken a hard look at that and some recent data and shown that that's not the case, that these people have not found jobs. They're still out there without health care coverage. So it's going to be a busy couple of weeks ahead. We're expecting, obviously, the decision in the Arkansas and Kentucky work requirements case. We'll see what comes down from CMS in terms of a waiver approval for Utah, given the fact that their enrollment under the partial expansion is slated to begin April 1st. And we'll see if CMS has some additional guidance in terms of what the block grant proposals are or what they're thinking about in terms of partial expansion. So we'd encourage you to stay tuned to what we're sending out here from Families USA. We'll be following all of this and sending out guidance as quickly as we can once some decisions are made in the courts or from CMS, and we'll be sharing that with you. So thanks for joining us today and getting a heads up on what's coming down the pike and where we are. We look forward to talking to you again next month on a new topic for our Health Action webinar. But thank you for joining us today, and good day.